Hello, everyone. My name is Dr. Neeraj Agarwal. I'm a professor of medicine and director of genitourinary oncology program at the Huntsman Cancer Institute at the University of Utah in Salt Lake City. Today, I have my esteemed colleague, Dr. Karim Fizazi from France. Karim.
Hello, everyone, and thank you, Neeraj. Really great to speak to you guys today. Karim Fizazi, medical oncologist from Gustave Roussy in France, and also the president of our GU oncology group here in France. And we will discuss about advancing patient-centered care in metastatic castration-resistant disease. We will specifically speak about PARP inhibitor combination today. Neeraj?
Yes, thank you, Karim. So much data have come up in the last few years, with the most recent data being presented in ASCO GU, that we thought it would be great to discuss PARP inhibitor combinations today. So let's take a step back and see what are the unmet needs in patients with metastatic castration-resistant prostate cancer. Even before I talk about the listed unmet needs, we know that median overall survival remained dismal in metastatic CRPC setting. And from the start of mCRPC, in those patients who have not progressed on ARPI, such as enzalutamide or abiraterone, the median survival still remains about 3 years. And half of our patients, even in the US, do not see more than one line of systemic therapy. So they get one line of systemic therapy, and half of them don't see the next line of systemic therapy. This is from real-world data. That is what is exactly happening in the real world. And there are multiple reasons behind it. And let's talk about the unmet needs focused on this talk today, or this discussion today. First of all, we know from the perspective of PARP inhibitor uses, there's a limited biomarker testing and awareness. We just published in JAMA Network Open, based on the Flatiron data from the US, that in 2022, or 2023, just like 2 years ago, number of patients who got genomic testing done in metastatic prostate cancer setting is less than 30%. Even though we have life-prolonging drugs like olaparib or other drugs targeting underlying genomic targets such as pembrolizumab, approved since 2019 and 2017. And there are multiple other implications of genomic testing findings. But still, we are seeing less than half of our patients undergoing genomic testing even now. Second, doesn't matter what we use in castration-resistant prostate cancer, these patients develop resistance to therapy. If we look at monotherapy data, we are looking at failure of those agents within months. It may be a little better with chemotherapy, or there are other therapies available. But then you talk about PARP inhibitor combinations, which we just presented. Obviously, the duration of response is much longer, but ultimately, patients are failed by whatever we do. So what can we do to avoid resistance or prolong the response to PARP inhibitors in metastatic CRPC setting? And then lastly, side effect management. Many of us see different types of cancer patients. And many of the colleagues are very used to using multiple chemotherapies in patients with different types of cancer. So side effect management, I think the most important part about side effect management is to understand how to manage those side effects. And I don't think any of us cannot manage these side effects. It's just the understanding of how to approach these side effects, how these are different from chemotherapies or many other agents, and just to preempt those side effects. We'll be discussing about that today. And then lastly, should we sequence these agents or should we combine these agents? In the metastatic prostate cancer setting, multiple trials have shown that combining these agents are more effective than sequencing of these agents, whether it is in hormone-sensitive prostate cancer setting or metastatic castrate-resistant prostate cancer setting. So we'll be discussing some data from the BRCA trial today. So before we move forward, these are the rationale for using PARP inhibitor with ARPI. And these are preclinical data which showed when prostate cancer cells are targeted with AR inhibitor, and AR is the engine of prostate cancer cells, like I explained to my patients. And I know many of the patients are here this digital media cast, if you will. So the way I explain to my patients, AR is the engine of prostate cancer. We block AR, and PARP, poly-ADP-ribose polymerase, comes to the rescue of cancer cells. So there is a crosstalk between AR pathway and the DNA repair pathway. So when you block AR and PARP at the same time, this approach has the potential to improve the effectiveness of PARP inhibitors. And based on this, multiple trials were designed and conducted in the last 3-4 years. Before we move to the data, and Dr. Fizazi will be discussing some of those data, I would like to bring your attention again to the recent guidelines we put together on behalf of ASCO. These were just published in JCO, Journal of Clinical Oncology, on January 9th. And we have tried to make it simple for our colleagues in the community. Who should get germline testing? Who should get somatic testing? And the bottom line now is everyone with metastatic prostate cancer should undergo germline testing and somatic testing, or what we call as NGS testing. There is ambiguity now. No, we don't have to, it's good to have family history, but it's just regardless of family history, regardless of what was the age of cancer in first degree relatives. So anyone who has metastatic prostate cancer should have both germline and somatic tumor testing. And not only for PARP inhibitors, we know that drugs are approved or will be approved based on underlying mutations, but also these mutations have in prognostication, in designing the monitoring plan, how often patients should come to the clinic. And I won't delve into those individual data yet, but every patient should go undergo germline testing and somatic. When the disease progresses and patients did not have
Oh, I wonder if we have lost Dr. Agarwal. I guess his connection was not that good. Maybe I should take over on that. Can we just move to the next slide for the sake of time? Yeah, okay. So let me comment on that, and I apologize for that. I guess Neeraj had some internet issues. So the slide's actually showing us what are the most frequent germline HRR mutations in men with advanced prostate cancer. Clearly, BRCA2 is the main player. It's very important, and you will see with the data, it's clearly predicting for efficacy. So it's really important to detect BRCA2 alterations. I'm showing here germline alteration, but this also applies to somatic alterations. ATM is numerically the second alteration we're seeing in germline. It's a long gene with many different mutations. We're just starting to understand which one may actually predict for benefit of treatment. And actually, we still need to develop ATM directed therapies. CHEK2 is also coming third in this ranking. Then BRCA1 is not very frequent in this disease, but you will see with the data that actually we need to detect BRCA1 alteration because they appear to predict for benefit. RAD51D and PALB2, and PALB2 is also clinically very important, even if it's rare. Next, please. Next slide. Okay, so we have a case of a gentleman, just to show you very practically um, what we can actually see, if you want, or expect uh, from benefit of combined therapy in patients with advanced disease. So this gentleman had metastatic disease who was treated some years ago with ADT and docetaxel. He benefited for 2 years and a half, which is quite typical. The time to progression is about a year and a half. And at this time, he had widespread skeletal disease, which is often what we see, of course. Advanced metastatic prostate cancer is a bone disease mostly. So this is what we call high volume, even if I don't necessarily like very much this name. But anyway, numerous bone lesions in a 71-year-old man who has exhausted ADT and docetaxel. The gentleman was started on enzalutamide plus talazoparib, and please make sure you pay attention to the dose of talazo. This is only 0.5 milligram daily, not the full classical dose of talazo when used as single agent. He developed a grade 3 anemia after a couple of weeks, or actually months. And talazo was then dose reduced, which is what is recommended, with a much better tolerance with a reduced dose. He's actually still on treatment, benefiting from treatment for approximately 44 months. Biologically speaking, his cancer analysis showed a mutation, a biallelic mutation in CDK12, and this actually predicts for efficacy. We now know it, and this was not something that we knew initially. So this is really showing you an example. So why did we use this combination? Well, I just show you data with enzalutamide and talazoparib, but we have also other combination. We did that because we now have data from phase 3 trials. Actually, 3 phase 3 trials are available. I see that Neeraj is back, and we're waiting for a fourth. So I'll start with Propel and Magnitude, and perhaps Neeraj will carry on with Talapro 2. So let's start with Propel. Propel is a phase 3 trial combining abiraterone plus or minus olaparib, classical randomization, large phase 3 trial, classical population of patients with metastatic castration-resistant disease, at least the old classical population. I'm saying that because these patients have typically not seen an AR pathway inhibitor in the castration-sensitive setting, in contrast to what we currently do mostly. Having said that, a small proportion of these patients, about 22%, had received docetaxel for castration-sensitive disease. Approximately 800 men were randomized on a 1-to-1 fashion, and biomarker analysis was analyzed post-hoc. The primary endpoint was radiographic progression-free survival, and the trial was positive, with a 34% reduction in the risk favoring the combination arm. For those of you who like medians, approximately 25 months in the combination arm versus approximately 17 months with abiraterone alone, and this was significant. Having said that, the trial could not show overall survival as a whole, and actually data are very different when you look at what's happening in patients with BRCA alterations or HR alterations versus those without HR alterations. And indeed, for patients with BRCA alterations, regardless of whether this is germline or somatic, the benefit is enormous, favoring olaparib plus abiraterone, with approximately 75% reduction in the risk of death. So that's really enormous. Now, if you're focusing on patients without HR alterations, and even more without BRCA alterations, the benefit is actually much more reduced and actually non-significant. We need also to be clear that this benefit, even for patients with BRCA alteration, does not come without some toxicity. PARP inhibitors induce hematological toxicity and sometimes GI toxicities. In Vestral Propel, we saw approximately 47% grade 3 or 4 toxicities, mostly anemia, approximately 16% versus 2% in the control arm. And there was also an excess in pulmonary embolism, approximately 7% versus approximately 2% in the control arm. So we need to know that before making a decision as to whether we should use these combinations or not in our patients. The second trial, actually, they came together. They really came out at the same time, was called Magnitude. And this time it combined abiraterone with or without niraparib. In contrast to what I said about Propel, the biomarker setting, the biomarker status, was analyzed upfront, and it was known before randomization, so that two cohorts of men could be defined, one without HR alterations, 600 patients were initially planned, and the other one with biomarker positivity, so with HR alterations, approximately 400 were initially planned. The cohort without alterations of HR was closed prematurely simply because there was no obvious benefit. Now, and actually most of what we know from Magnitude comes from the other cohort, that with HR alterations. And here again, we see a benefit when combining niraparib to abiraterone with a median of in a radiographic progression-free survival of approximately 20 months versus approximately 11 months in the control arm. And this translates into a reduction in the risk of approximately 45%. Also, and very interestingly clinically, when you focus on patients with BRCA alterations, it appears that combining niraparib with abiraterone postpones significantly the time to symptomatic progression, with actually approximately a 45% reduction in the risk. And again, clinically, this is very important. We don't want all the patients to develop symptoms. But again, there's no overall survival in the trial shown as a whole. Clearly, for patients with BRCA alterations, we do see improvement in overall survival with, again, 45% reduction in the risk. As I said before, combining a PARP inhibitor with an AR pathway inhibitor does not come without some safety signals. And here again, we saw an excess, for example, in thrombocytopenia in disfavor of the combination arm. Now, the third trial, which came approximately a year later, is called TALAPRO-2, and this is combining this time enzalutamide plus or minus talazoparib. But please, Neeraj, if your sound works again, would you mind taking us through the data, please?
Absolutely. Thank you, Karim. So TALAPRO-2 trial is the most recent entrant, especially with the overall survival data we presented in the ASCO GU just a few weeks ago in San Francisco. So first of all, I would like to take a step back and tell you that TALAPRO-2 is basically, there are two trials in one trial. So we recruited about 800 patients, all-comer patient population. They had newly diagnosed metastatic CRPC, and they were randomized to enzalutamide plus placebo versus enzalutamide plus talazoparib. So moving forward, I'll just mention enzalutamide instead of enzalutamide plus placebo. Radiographic progression-free survival was the primary endpoint, and overall survival was a key secondary endpoint, which was alpha powered. So it was statistically, trial was designed to answer the overall survival. And we presented the earlier data on radiographic progression-free survival in 2023, where we showed that there was a 33% reduction in risk of progression. We updated the data in the ASCO GU.
there was a 14-month improvement in radiographic progression in all-comer patient population with talazoparib. So if you look at enzalutamide, RPFS, it was 19.5 months, about 20 months, very similar to the PREVAIL trial, which led to approval of enzalutamide. But then you look at the enzalutamide plus talazoparib, it was 33 months. That is a remarkable improvement in overall survival, in radiographic progression-free survival, because progression-free survival basically means delay of complications, delay of symptoms, delay of pain in our patients with metastatic CRPC. So that was quite statistically and clinically meaningful improvement in PFS. Now, if you look at the overall survival, we saw a 20% reduction in risk of death with talazoparib. So if you look at the absolute numbers, 37-month was the survival with enzalutamide. And that is similar to what we have seen in enzalutamide monotherapy trials, a little higher because of recent therapies. But I think it was very similar. But if you look at the combination of enzalutamide plus talazoparib, it was 46 months. About 9-month improvement in overall survival by adding enzalutamide to talazoparib in patients with metastatic CRPC, and these are all-comer patient population. So quite striking benefit in this patient population, both in terms of PFS and OS. If you look at the subgroup analysis, all patients seem to benefit. If you look at patients who did not have BRCA alterations, so question often arises like, is it confined to BRCA1 mutations or not? There was an 11-month improvement in overall survival in patients who did not have BRCA1 or BRCA2 alterations. And there was about 9 months improvement in overall survival in patients who did not have BRCA1 or BRCA2 or any HRR gene alterations. And I'm giving this absolute numbers because that helps us with decision making in the clinic, especially with the patients. We did not see any compromise in the quality of life. And coming to the side effects, as Dr. Fizazi just mentioned, I would like to mention that anemia was the most common side effect. Grade 3-4 anemia happened in 49% of these patients. But just to take a step back, 49% of these patients had grade 1-2 anemia to begin with before they go on the trial. And the median duration of onset of anemia is 3.3 months. So what I do in my practice, I follow these patients with monthly CBCs, and I know who is going to develop grade 3-4 anemia, and I decrease the dose either the moment they develop grade 3-4 anemia, or when the hemoglobin is already gone down from 14 to 11 or 10, I know they are heading to develop grade 3-4 anemia. So after discussion with the patient, I decrease the dose preemptively when the hemoglobin is moving down fast. But once we decrease the dose of talazoparib, these patients seem to tolerate talazoparib pretty well, as evident by almost 20 months treatment duration of talazoparib. So if you look at median treatment duration of talazoparib in this trial, it was 20 months, and only 8% of these patients discontinued talazoparib because of grade 3-4 anemia. But if you look at grade 3-4 other side effects, nausea, vomiting, they're pretty rare, actually, fatigue, anorexia, happening in 1 to 4% of these patients. So I think preemptive treatment of these patients with these symptomatic medicines is the key. For the HRR positive patients, the magnitude of benefit was even higher. And I'll let Dr. Fizazi take over this. Karim, thank you.
Sure. Thank you, Neeraj. So basically, as Neeraj explained, we really have two different phase 3 in TALAPRO-2. One is about all-comer patients, and the other one is really about patients with known HR alterations. Approximately 400 men were randomized with those alterations. We reported the data first about 2 years ago. Radiographic progression-free survival was a primary endpoint, and what we saw was a quite, I think, impressive 55% reduction in the risk of progression or death. We just updated the data at ASCO GU this year with a much longer follow-up. The hazard ratio remains exactly the same, but now the medians have been reached, which and the RPFS median is just a year in the control arm with enzalutamide alone, as compared to 41 months for the combination, which I think is quite meaningful. Now, of course, it's very important to dig into the details when it comes to rPFS, but also overall survival. As a whole, for this population with HR alterations, the trial again is positive. Overall survival is significantly improved, and actually by approximately 40% when it comes to the reduction in the risk of death, which of course is very important. Medians are reached 31 months in the control arm versus 45 months in the experimental arm, which again is really provocating because, as Neeraj said initially in his introduction, patients with metastatic CRPC typically don't live very long, and those with HR alterations typically have even a worse outcome. So 45 months of overall survival is really something for this month, for these patients. Now, again, digging into the details, for BRCA patients, either BRCA1 or BRCA2, the median is not even reached with talazoparib and enzalutamide, where it is for patients in the control arm with approximately 28 months, again reflecting the aggressivity of this subgroup of cancers. The hazard ratio is approximately 0.5. So in other words, we're reducing by half the risk of death for these patients with BRCA1 or BRCA2 alteration, which is really fantastic, I think. Now, for patients with non-BRCA HR alterations, the benefit is more reduced, 32 months, approximately 43 versus 42 months. The hazard ratio is more 0.7. And the difference is not significant. It's the p-value is 0.06. And actually, I think it really reflects the heterogeneity of that subgroup of men with HR non-BRCA alterations. For example, if I take patients with CHEK2 alterations, typically we don't really see much benefit from a PARP inhibitor. While, as we showed in the case we presented, if it's a man with either PALB2 or CDK12 alterations, they may actually derive benefit from receiving talazoparib on top of enzalutamide. The other trial, it's not a phase 3, it's a randomized phase 2, but we think, Neeraj and I, that it's an important one. It's called BRCA. So it's looking at various way to use abiraterone and olaparib. Neeraj, can you take us through this data, please?
Of course. Thank you, Karim. So BRCA is a small trial, IIT trial. Many of us came together, led by Dr. Maha Hussain in Northwestern, and we recruited patients to 3 different arms, 20 patients on abiraterone, 20 patients, 20, not percent, on olaparib arm, and 20 patients on abiraterone plus olaparib. Small trial, so please keep that in mind. However, patients with abiraterone were allowed to cross over to olaparib after disease progression. And patients who had olaparib initially, they were allowed to switch over to abiraterone. And then patients in the third arm, they received abiraterone plus olaparib. So if you combine the progression-free survival of abiraterone followed by olaparib, or olaparib followed by abiraterone, it was 16 months. And if you look at those patients who got abiraterone plus olaparib, the PFS was 39 months, which is very similar to what we saw in TALAPRO-2 or PROPEL trial. And the lesson I learned from this is that, first of all, it's good to see, this was the first trial actually, which was asking this question about abiraterone versus olaparib. I don't think any of these trials have answered, the phase 3 trials have answered this, but the suggestion is that sequencing probably is not as good as combination upfront. And we also lose patients. So a lot of patients could not actually get olaparib after abiraterone, and also a lot of patients could not get abiraterone after they had progression on olaparib. So this trial, even though it's a small trial, I think I'm convinced, based on my own experience, that combination strategy is better than sequencing. And whenever I get a chance to combine agents, I like to do that in my practice. So with that, I think we are running out of time, but still we like to conclude the discussion with these concluding remarks that many patients we who develop mCRPC have not been exposed or have not progressed on AARPI. We continue to see those patients in the real world, and many patients have received limited duration ARPI in the past, and we'll see those numbers going up with many trials reporting. So there will be a substantial number of patients moving forward who have either not progressed or not exposed to ARPI. And based on these results, there is no doubt that there is a synergy between the PARP pathway and the AR pathway. Either we look at these big trials or BRCA trial. And based on that, I like to continue to make sure every patient of mine undergo genomic testing and germline testing. There is no substitute for that. There are implications on the family. We didn't mention that. So there's no excuse to not do testing in our patients. And then patients who are progressing on ADT and docetaxel and who are developing new mCRPC, I give them an option of enzalutamide plus talazoparib and other PARP combinations. If they have BRCA1, BRCA2 mutations, for all HRR mutation positive patients, we have enzalutamide plus talazoparib available in the clinic right now. And next steps are to look for why patients stop responding and what are the mechanism of resistance to these agents. I think PARP inhibitor story doesn't finish here. It will continue to evolve. So stay tuned, and we'll continue to inform you of further development in the field. Karim, did I miss anything?
I think this was perfect. So thank you very much, Neeraj. And thank you all for listening to us today.
Thank you.